This podcast is for educational and entertainment purposes only. The views and opinions shared are mine and my guests alone and don't represent our employers, past, present, or future. Medicine is always evolving and practices may vary. Nothing here should be taken as medical advice. Always follow your own professional judgment and institutional guidelines.
So now you have a 9-year-old who feels completely fine, and you have to communicate to her that she has to have heart surgery and they have to open up her chest and put her on bypass and stop her heart and put a cadaver patch on her aorta and explain what cadaver is and all that stuff. And realizing that now, leading up to this, most of that communication was towards the parents and family. And now you have a patient that is appropriate and can understand those things as well. So it's that communication piece to both and including everyone in that aspect, patient and family alike.
Welcome to the Beyond the Call Light podcast with Gary, the ER nurse, where we tackle the tough topics in nursing. Update your whiteboards and huddle up because this episode begins now.
Welcome back to the podcast. This episode, we're going to be talking with Christopher from the Blakery Content. My name is Gary, the ER nurse, and you are listening to Beyond the Call Light. Christopher, we're going to get right into this. I've been looking forward to this podcast episode for a very long time, since I first found you on TikTok, and your content was just incredible, educational. I thought, I got to get this guy on here, and I'm so excited that you are finally on the podcast. So if for those that don't know who you are, can you please just give a little information about yourself and your background?
Yeah, absolutely. Thanks for having me. I'm super excited as well. I've been looking forward to this since we first started chatting. So I'm Christopher with the Blakery Content, a healthcare provider that's been doing this just over 24 years. Started out as a firefighter, EMT, progressed through paramedic, ended up becoming a pediatric flight paramedic, and then on to nursing, where I went in all sorts of different routes and worked in different departments, and ultimately ended up as a pediatric and neonatal critical care flight nurse, and now still working as a flight nurse with a program that does both adults and pediatrics. And then obviously the Blakery Content side of it is a little bit more of the education piece and just focusing on pediatric readiness and bringing awareness to pediatric patients.
Now, what drew you specifically to pediatrics? Because that seems to be kind of like the focus of your educational content. So what drew you to that?
Yeah. So when I first started out, I tell the story. I was in my 20s. I started out as a firefighter, paramedic. And at the time, I didn't have kids. I didn't want kids. I didn't know how to talk to kids. I didn't understand anything about it. And I had a couple calls at the fire department where, we responded to a pediatric patient, and I call it that pucker factor, where your butthole puckers because your heart rate's up, you're uncomfortable, like you just don't know what to do. So I just started taking every pediatric course that I could and just tried to prepare myself a little bit more because I didn't like that feeling. They were calling me for help. I didn't want to show up and not be able to help and rely on the family more than what I could provide. So I just started diving into it, and ultimately, like I said, ended up as a pediatric and neonatal critical care flight nurse with 2 kiddos that completely control my every moment. So, but the goal for me, though, has been reducing that pucker factor for other providers, right? And ensuring that, the pediatric patients get taken care of the same as our adult patients do. And we know that the call volumes that we deal with our pediatric patients are very low. So it kind of, the experience and training and all that stuff lacks as well. So it's just really been the driving force for me is to reduce that pucker factor for other providers because I know exactly what it feels like.
Now, for listeners who may not be familiar with the flight world, can you briefly just kind of give an overview of what a typical day looks like for a flight provider?
Sure. So we arrive early for our shift, and first thing that we do is we complete a risk assessment. So we determine, how much sleep did we get the night before, how many shifts have we worked in a row, how much experience we have. So a lot of, contributing factors that may put us at a higher risk for an incident, because in the flight world, everything is safety based. So safety comes first. We do that, and then we start our morning check. So we do a little handoff from the offgoing nurse to the ongoing nurse, talk about what they what they went through the previous shift. And then we hand off the narcotics and we do drug counts and make sure everything's there. And then once that's done, we pull blocks for our cooler for blood. We carry 4 units of whole blood with us on every mission. So we have to condition the blocks so that they can stay cool for the day. And then we head straight out to the aircraft and start checking the aircraft and essentially pull everything out of every pocket, out of every bag, test the monitor, test the ventilator, and make sure everything is ready to go at a moment's notice. And then usually, if we time it right, we get that done right about the time of our shift brief. So we do a safety brief or huddle every day with our pilots and the med crew, and then also our dispatch center, our FCO, and all the other assets within the organization. So all the air bases, all the ground units, everyone comes together in like a virtual meeting, and we go through our safety brief. And then once we're done doing that as a big group, we have our smaller one specific to our base, where we talk about weather, expectations and safety stuff. And then from there, the day is kind of ours. We do quality assurance stuff where we review charts and do reach out to agencies that we had provided services for in the last 24 to 48 hours and give them updates on patients and do that kind of stuff. And then really it's education, self-driven education. And then we're fortunate that we have quarters similar to a firehouse. So we're able to like make breakfast or bring food and heat up. And then we're on that just state of alertness, right? That constant ready to go. The moment that pager goes off, we're expected to be out of there pretty quickly. The goal is to be in the air and within 7 to 8 minutes, which is a lot of moving parts to get going. So
I mean, the pre shift, all the checkoffs is similar to like if you do ground, like you got to check your rig off, you got to take everything out, check expiration dates, all that stuff. And then in the hospital environment, we got to check our Zols, we got to check, the Omnicell or the Pyxis, we got to do all of our checks. So it sounds like there's that similar component if you work in pre-hospital as well as in hospital. So that's interesting. And of course, obviously when you fly, you want all that stuff to be where you need it and make sure that it all works. So now what are some unique challenges? If you've worked in EMS or in healthcare long enough, you've heard that, children are not small adults. But then we're kind of seeing this transition back to, well, kind of they are. So what are some of the unique challenges managing pediatric patients in like pre-hospital or transport compared to adults?
Yeah, I think a lot of that comes down to readiness, being prepared to manage those patients. And there is that thought process. Like we for years said that pediatrics are not just small adults. And as you just mentioned, there is kind of that push where in some cases, they essentially are small adults in the fact that we treat them the exact same way. The algorithms are the same, the medications are the same, but there's changes in dosing, right? So weight-based dosing is one of the probably biggest issues where we see errors in our pediatric patients. So those are some of the concerns there. But a lot of the processes, a lot of the way that their bodies function is the same as adults. There's little things that are anatomical difference or developmental milestones, right, that are going to change based on their age, but overall those systems function the same. And that's where a lot of programs, they used to do a very small section of pediatrics, like it was a couple weeks in the middle of the course. And now a lot of them are moving to expanding that over the entire curriculum. And when they're talking about respiratory, including the pediatric component into that respiratory and tying it all together, because a lot of those treatments are the same. And when you can correlate that with the adults, it reduces some of that fear and concern that this is completely different, because it's not.
Mm-hmm. Now, are there any misconceptions about pediatric emergencies that you like when you do these educational components of the flight, which is a huge part of what flight crews do, is they go out in the community into whether it's a local rescue squad or just teaching a class on specific things. But are there any common misconceptions that you have to address repeatedly when you go out into the community to teach about this stuff?
I think one of the big things that I talk about a lot is family presence and including them in the process. I think there's a lot of uncomfortableness, right, around having family there, especially in a full arrest situation. And there's a lot of that just load and go and treat with diesel, and that's just not the case. There's evidence out there that supports staying and playing, and time to first dose epi plays a role in positive outcomes of these patients. Trying to get that mindset of just because it's a kid, we need to get them to the hospital as quick as possible. Again, the adult world has transitioned over, at least in our region, where they are staying on scene for 20-25 minutes and actually doing field termination after those 20-25 minutes. And people are like, well, we would never do that with pediatrics. And I will tell you that they are doing it, and they are doing it successfully in certain parts of the country. And the evidence supports having that family presence, and rather than that roller coaster of emotions of someone just showing up to your the curb or driveway and scooping that kid away from you and racing to the hospital, and then you have all that unknown time in there.
Right. Is there, over your career, and I know you've been at this for 20 plus years, is there one piece of equipment or protocol that you feel has been a complete game changer when it comes to pediatric care in the transport world?
Ooh, I think yes. So I'll say without referencing a certain brand or whatever, but I think references, whether it's an app or a like a reference book,
Hmm.
I think that is the absolute game changer, right? There are apps out there now, and
Hmm.
everyone can assume what I'm speaking of, but there are apps out there now that you literally can put in the patient's age, and it's going to give you the ideal body weight. It's going to give you all the medications. It's going to give you, and what's big for me is it doesn't just give you the dose, but it or per kilo, it actually gives you the volume you're going to draw up. So it reduces all of that calculations, and you literally just type in their age and it pulls it up, and then you can actually pull up your protocols within there based on what you're treating, and then that reduces that cognitive workload. It gives you the ability to have all those resources. When I started out, when we would go in and do ACLS and PALS, we had to go in
Hmm.
and do these mega codes to where you couldn't look at anything. You were by yourself. You had to have all that memorized.
Right.
And that's just not the case anymore. It's important to understand that there is a difference, and, like normal vital ranges. Like, we understand that the vitals are different for different age groups, but you don't have to take all that to memory. Like, know there's a difference, know where to find that information. And I think these apps and resources is really changing the game. And
It's what we call cognitive offloading. Like, that's
right.
the things that you can reserve some of that brain power and space for more critical things, and then just use those tools at your disposal to fill in the gaps and not necessarily waste that brain power on those kind of things. And plus,
Absolutely. And,
I,
and
I think there's less room for error when you're pulling up those established resources, because in your mind, you can always make a mistake. But if you have that reference that's verified, then you're good to go.
Absolutely. And the nice thing with having it being age based is that, you almost always have the age of the patient en route.
Hmm.
So you can start pre-gaming before you even get on scene. And, that's where I have the video of like the tape on my leg
Right.
of looking at those references and having those doses ready to go, so that when I get bedside, I'm not having to calculate any of that. I'm able to just, my mind is focusing on making those critical decisions I need to make in that moment. And I've
Hmm.
already offloaded all those stressors of dosing and what size laryngoscope blade or ET tube I'm going to use. And it's all preset for me when I get on scene.
Right. All right. So, you've got on scene, you've got this patient, and you've now decided it's time to transport this patient. You've done all you can on the scene, and it's time to get that patient to the hospital. Now, when you get there, when that child arrives at the emergency department, what are some communication pitfalls that you have seen between like flight teams or critical care transport teams and the ED staff, and how can we fix those?
Yeah. So I think it's interesting that you mentioned that because we actually are working on this at the state level of trying to set up it was designed to be pediatric focused, but would work across the board and having more of a structured handoff process. I
Mhm.
feel like we have that with trauma, the missed report. Do you guys use that in your area?
Yes. Well,
Okay.
I work at a VA hospital now, so we
Oh,
don't do
that's right. Yeah.
pediatrics, but when I worked, yes, we had the missed report.
Yeah. So it's just more of that standardized structured handoff. And I think what's so important for the ED to understand, and a huge frustration point and dissatisfier for the EMS side, is that when you get there and you're trying to give report and you're constantly interrupted, right? If the receiving team just kind of took that moment, stepped back and let them listen, and I think we're getting better at that. But that handoff piece is sometimes you just need to be quiet and listen. And then if you have questions at the end, but most often, if you just listen to everything that they're going to say, they'll provide you all that information that you want. So I think having that structured handoff, if we could do that more consistently, would be a satisfier, but then also uh, patient outcome improvement.
Now, you've been presenting a series of pediatric emergency presentations at various conferences. You just did one in October in West Virginia, if I'm not mistaken. And then in November, depending on when this episode airs, you'll have already given it or are about to give it. And you talk about the pucker factor, but this is one of the main reasons I wanted to get you on here. And I'm hoping you can give us a little more information about this series. And is there a way for people who have not, who can't get to these conferences, for them to see this content?
Yeah. So the second question is not yet, but there will be. I'm
Okay,
working
good.
towards getting this course as a CAPC approved CE course that could be
All
available
right.
online for people to log in and check out and get CE for that. So that's one of the things that's coming along with a family centered care one that is focused specifically on family centered care. But yeah, going back, yeah, I just gave this at the West Virginia Pediatric Symposium, and I'll be in at the International Trauma Life Support doing this in November. And it's called reducing the pucker factor through improving pediatric readiness, and it that's what it comes down to is being more pediatric ready. And I give some foundation of ways that agencies can move forward with doing that. So I really start out the lecture talking about the statistics of pediatrics and letting them understand, what those call volumes look like. And we know that pediatrics are maybe 6 to 8% of an agency's call volume, and
Hmm.
that's for an agency. So that's not even the individual provider.
Right.
And there's some agencies that are seeing fewer than 8 pediatric patients a month, and even fewer than that. So for some providers, that may be 0 or 1 pediatric patient that they see a month. And then you take that to the high risk, low frequency ones of like a full arrest or a severe trauma or intubation kind of thing. Those are even fewer and far between.
Right.
And then, we kind of dive into why does that even matter? And when you're not experiencing that, your muscle, you lose that experience. You may have been taught how to put it in an IO or intubate a pediatric patient in school, but if you're not refreshing on that, you're going to lose that muscle memory, and you're in those high stress critical situations, you're going to be kind of fumbling over that. And then the other part that I go into is PEC. So I introduced the term PEC. It's PECC, so Pediatric Emergency Care Coordinator. And this is one of the biggest ways that agencies can impact pediatric readiness for their services. And essentially, it's just somebody that is a champion for pediatrics. And they make sure that you're doing pediatric education and making sure that pediatrics is included in your protocol development and ensuring that you have the right equipment. Now, they don't have to do all that work themselves. Like, they certainly don't have to provide the training. They just have to make sure that it's happening. And the kind of the running joke is, if you're asking who the PEC should be, it probably should be you. Yeah, and so it's one of those things that it's having that champion that is just kind of constantly cheering for pediatrics and being like, "Hey, like, we haven't done a ped sim in a while," or, and just kind of keeping it at the forefront so pediatrics doesn't become an afterthought. And then the other part of that is family-centered care, which I could talk all day about, my passion with that and just including the family. And then the last part is QA/QI and making sure that we're doing quality improvement, because it serves no purpose if we don't have that feedback loop of information getting back and then driving all the education that we're doing. So those are the four objectives from that lecture.
Now, without obviously being HIPAA compliant, can you walk us through maybe a case that kind of shaped your practice or your teaching philosophy? What lessons did you learn from that, with regards to like teamwork, preparation, communication?
Yeah, I think I was very fortunate that when I started in nursing, my very first position in nursing was in the pediatric ICU. And I worked for a regional pediatric center that just fully embraced family-centered care. And so that meant I was exposed to that very early on in my career. Like, family was at the bedside constantly. And when I transitioned from EMS and even as a pediatric flight medic to the ICU, I was very concerned about that family interaction and having the same patient for multiple hours or even multiple days. And I ended up having one patient that actually I took care of this patient almost every single shift for almost 4 months in the ICU. And so this was one of the sickest kiddos I had ever seen. And obviously the family was there all the time. And it got to the point that, the continuity of care was amazing because I knew this patient in and out. Like, if something very subtle changed, I knew because I had that patient day in and day out. But it got to the point that, like, the family would call in the morning to get updates and they'd be like, "Good, it's you. We're going to stay home with the other kiddos for a little extra longer and we'll be up a little later." And just,
You.
yeah. And we had that relationship and they knew that I was going to fight and advocate for that little kiddo through the entire shift. And it ended up being one of the things I was most scared about going into the ICU, ended up being one of my favorite aspects of that continuity of care and having that same patient over and over, but then also that family interaction. And I had multiple families that just got to the point, and I carried this over into my adult world when I left there, including families in and doing end of life. And I know we've talked about my passion with palliative care and just having those conversations and carrying the things that I learned in the pediatric world to the adult world. It has truly impacted the care that I provide and the response from the families.
Quick break from the conversation. If you're enjoying Beyond the Call Light, please don't forget to follow the show wherever you listen. You can find us on Spotify, Apple Podcasts, YouTube, and Amazon Music. Hit that follow or subscribe button so you never miss a new episode. And if you're on Apple or Spotify, a quick rating or review really helps others find the show. Speaking of which, let's get back to it. You talk about this family-centered care and how important it is to have family at the bedside. And that's certainly one thing to say as a clinician, but you have experienced that as a parent of a child who had a significant medical issue that required a significant surgery. Can you kind of give us your experience from the other side of that equation as a parent at the bedside?
Yeah, absolutely. So my daughter Aubrey ended up being a congenital heart patient. She had what's called coarctation of the aorta. And we discovered this when she was only 7 days old, and she ended up having surgery when she was 10 days old. And I remember standing in the PICU that I later ended up working in. I was standing in there, and it was at the hospital that I was flying as a pediatric flight medic for. And we're in the ICU, and they're doing rounds, and the medical director for the flight program walked by, saw me in the room, and like waved and kept on going. And then he got a couple rooms down, and then he realized, he was like, wait a minute, he was in jeans and a t-shirt, and came back, and he had no idea that we were admitted and in the ICU. And
Wow.
having working with these providers and previously, and then now being in there on the other side, what I call on the couch or on the other side of the room, right? And it was incredible to see all of those pieces come together. And up to this point, I had only done pre-hospital, and we would drop them off in the ICU and not get to see what that long-term process looked like. So
Mhm.
I was living at the hospital in the ICU for 8 days and getting to see all of the interactions, getting to be involved in rounds, and seeing all that work that goes into caring for these patients. And the biggest thing that I desired when I was in that role was communication. I wanted to be in the loop. I wanted to know what was going on. I wanted to know what the plans were. And those are things that I've carried over. And I think communication, whether it's good news or bad news, I just want the news. And I've certainly included that into the care that I provide, and including that family in there based off of those experiences of being in there with Aubrey. And then, coming back to, so she was only 10 days old at that point. Fast forward to her second procedure. So now you have a 9-year-old who feels completely fine, and you have to communicate to her that she has to have heart surgery, and they have to open up her chest and put her on bypass and stop her heart and put a cadaver patch on her aorta and explain what cadaver is and all that stuff. And realizing that now, leading up to this, most of that communication was towards the parents and family. And now you have a patient that is appropriate and can understand those things as well. So it's that communication piece to both, and including everyone in that aspect, patient and family alike.
Now, I've got 3 kids, and all 3 have had some type of procedure, surgery. One's had more extensive surgeries, a couple of them. The other ones have had fairly minor procedures. And I think for me, even with something that I would consider, any procedure, there's always a risk involved. Now, mine have not been through anything like yours have, but I will tell you from my experience, and I was in uh, the medical profession for 2 of the kids. My oldest one, I was not. But I think the thing that stands out to me was that once they take them back to the OR, there's that, there is that fear, right? Like, you can't go with them in their most vulnerable moment, and they can't
Mhm.
have their parents there. And I think that stuck out with me. And the other thing was, uh, like you said, there was a lack of communication. Like, my wife and I are just sitting in this room waiting, and there was nobody to walk us through what was happening. Now, I think once they might have come in and said everything's fine, they'll be out in a little bit. But I feel like to have somebody there that checks on you, right? Because that is a high anxiety time for a parent when your child goes back to an operating room, especially little
Mhm.
kids. And you just, I don't know. I feel like that component is missing in
Yeah.
healthcare, at least in the facilities that we have been to, and it's been multiple. So from my perspective, the communication is huge, and it's not just at the bedside. It's like when they take them away, that's the most important time for me. You need to give me updates. I need to know what is happening to my child.
Right. Yeah. So a couple things there. the and I tell this, the hardest thing that I've ever done is I actually got to walk Aubrey back to the OR for her surgery when she was 9 years old. And it was we had communicated and talked through this procedure so much that she was completely on board with it. Like, she woke up that morning and was like cheerful, and she's like, today's the day for my surgery, and we go and we get there and we do all the pre-op things, and we talk to the staff because she really wanted me to walk her back to the OR, and they were okay with that. And so we're sitting there, and I turn around to sign the consent, like right before it's time to go back, and she was fine. I signed the consent, and I turn back around, and she is just sobbing. And she's like, I don't want it. I don't want to do it. I don't want to go. And I'm like, I'm like, Aubrey, I get it. I said, like, you understand the why behind this. Like, this is one of those things that just, we have to do. And so I got to hold her hand and walk her back to the OR, and we get into the OR, and I knew the anesthesiologist. I knew the CRNA. I knew the surgeon, like, personally knew them. And we get back there, and I lift her up on the OR table, and as they are masking her, putting the mask on to sedate her, I'm physically holding her down as she's crying through the mask, saying, I don't want it. And again, it was the hardest thing I ever did. And she went to sleep, and I was comforted in the fact that I knew the care providers taking care of her. I had total faith in the procedures and that kind of stuff. And I talked briefly about some of the things that we did going into that. And all my only goal was that she woke up and was still Aubrey. That's all I wanted, was for her to wake up and still be Aubrey. And so I walked out of there, and I walked straight to the bathroom, and I locked myself in the bathroom, and I just cried for probably 20 minutes straight. And then that's where I jumped on TikTok and made a case of, like, can we, reached out to EMS TikTok and was like, can you please just send some support and love? Because Aubrey had been making TikTok videos up to that point.
Right.
And so she had some following. So I just reached out and was like, so that when she wakes up and is still Aubrey, we have positive comments to read. And yeah, but that's what I literally was like, still tearful. And I'm like, I just did the hardest thing I've ever done in my life. And still to this day, like that. And that was somebody that knew the care providers in the room, knew the process, knew exactly what was going to be happening. And then it still hit me like that. So I feel like that's where I want to give that same respect to other families and people, so that they feel like they're included in that care. And then when I was out waiting in the surgical waiting, like, the PA came out multiple times and gave us updates and constantly kept us up to date. So there was not very long windows without updates. So again, that was, I was very spoiled by the process. And that's what drives me to just provide that same care to other families.
That was emotional. Let's take a deep breath here.
Yeah.
So, but that kind of ties into my next question, and that is emotionally. Like, especially if it's your kid, that's emotional. But as a parent, anytime there is a sick or injured child, like, I think it's very difficult for a clinician who has children not to put yourself in that child's parent's position, right? How do you, like, personally decompress or process all of that when you run one of these really difficult pediatric calls?
Yeah, it can be challenging. And I think part of that is the readiness, the pediatric readiness side of having that confidence to manage that patient, right? Because if you show up and you rock it, and you do provide a high level of care for these patients, regardless of the outcome, even if it is a poor outcome, like, you walk away knowing, like, I legit just did everything that could possibly be done for that child. Again, regardless of the outcome. So I think that plays a big part of it. The other part for me is, again, understanding that there are more than one patient when you're dealing with a pediatric patient. So you're taking care of the child, but you're also taking care of that family and having, supporting that family in that aspect. And then when it comes to after the fact, for me, it comes to I was spoiled very early on again in my career. In 2001, 2002, when I started in the fire service, I told the story. One of the first auto accidents I ever responded to was a quadruple fatality accident.
Mm,
And I was 20, and the occupants were between the age of 20 and 24 or 26. And like it bothered me. I would go do something and I'd be like, well, they're never going to do that again. And it hung with me. And I had one of the guys at the fire department tell me, I think it was two different people, but two statements that will live with me forever is one of them said, you know, once you understand that you didn't cause it and you're just there to help and make the situation as best that you possibly can. And then the second part was don't ever bury it and just talk about it. The more you talk about it, the more that you will become comfortable with it and accept it and just never just bottle it up. And these were things that were told to me, like I said, 2001, 2002, when mental health was not allowed in the fire service. You know, it was you knew what you signed up for and you bury it down and there are no emotions. And so those were things that were taught to me at a very young age. And I've carried those with me. Like I understand that I didn't cause it and I'm going to do everything in my power to make the situation better. And if I can't fix the patient, I'm going to make the situation as best as I can for the family. And then when I'm done with it, I'm going to talk about it.
and that I think we've made a lot of progress in terms of mental health awareness. I think we have a long way to go because I still think there is this mentality in EMS and the fire service to keep it down and suck it up buttercup kind of thing. Um uh do you do you do you feel the same? Like, do you feel like we've made progress but we still have a long way to go? And if so, like, what is holding us back? Like, why do we still have pockets of EMS and fire that are still not on board with mental health?
Yeah, I do agree. I think we have come a long way. I think the fact that we're even talking about it is a significant improvement from when I started out. I think there's a couple things. I think traditions die hard. I think that funding is also an issue. But like you said, we have made some progress. We're talking about it, but what are we actually doing? Are we actually implementing it? And I think it was Nightmare Medic that had made the comment that he's like, yeah, we're talking about it, but who's actually stepping into it and who's actually seeing it through? Like, are we just walking around with cards being like, here, we offer peer support, but
Right.
are we actually doing it? And I think some of that challenge is I think personally, a lot of us don't know how to manage it and we don't know how to help other people in that capacity, to provide those services. And I think a lot of us we're so busy that it almost feels like there's times that like I care about you and I want to support you, but I don't know how. And I don't know if I dive into this, how much can I give you because my cup is already pretty low. So it's like how do I stay afloat and still support how much how much do you need and how much can I give you?
Right.
Does that make sense? Like
No, yeah.
I think there's a huge time constraint. And it's like when you say, how are you? Good morning, how are you? Like, do
Loaded
you really
question.
want to know how someone's doing or is it a nicety and moving on? And I think
Right.
you have to be able to, if you're going to ask those questions, you need to genuinely ask them and you need to step into it. And I'm not sure that we're doing that and myself included in that.
That reminds me, there is a housekeeper that works in the ER, and Shay, and she's wonderful. And so whenever I see her, I'll say, "Morning, Shay. How you doing today?" and she will look at me and she'll go, "I'm okay." And I appreciate that. And there are days when I can see it in her face and I'll be like, "Are you sure you're okay?" Because most people say, "I'm doing great," or "living the dream," but you seem honest in your opinion about, like, when you say that, like, "I'm okay." And she said, "Yeah, I'm okay. I'm not great. I could be worse." And I was like, "Well, I appreciate that level of honesty." But I told her, I said, "Look, if you're ever not okay, it's okay to say that too. And I'm happy to sit down and talk with you if you need to." So, and of course, when you offer that, I am genuine about that. I mean that. How many people are going to take me up on that? And I think that part of that fear is like they don't want to feel like they're a burden on that person.
Absolutely. So I have a couple buddies that struggle pretty hard in this realm, and that's one of the reoccurring comments is I don't ask for help because I don't want to be a burden. I already feel like I'm a burden, and it's like you're not. Like I'm here for you. And somebody else made the comment that like if somebody is actually talking to you,
Mhm.
like just fully listen and accept it, because that's showing that they are comfortable with you and want, that they feel comfortable talking to you, and just be that person for them.
And I will say one of the other obstacles I think is, and I think you touched on this briefly, is cost. And as somebody who has been to therapy, that is not cheap, and it's gotten more expensive. Like a copay for, whether it's a therapist or a psychiatrist, I mean, that can run anywhere from $30 to $50 per session. That is a substantial cost, especially in today's environment. And yes, the EAP, the employee assistant plans that most organizations are going to offer, is what, I think 4 visits, and then after that you got to start paying the copay. So I think that is another, even these online ones where you can just do a virtual one, that's still, a lot of them don't take insurance, so it's going to be an out of pocket cost. So I think we have made getting mental health help cost prohibitive for most people. I do pretty well, and it is an additional cost to my family when I go. So I think we need to address that as well. And I feel like if you work in a high stress environment, fire, EMS, healthcare, I feel like we got to have those that are readily available and included in your benefits package. That's
Yeah.
my thought.
And so fortunately, in the state, so in Ohio, I sit on quite a few of the EMS subcommittees and boards at the state level.
Mhm.
And talking about strategic planning for the future, one of the discussion points is mental health and resiliency for first responders, and how do we as a state support those initiatives and that kind of thing. So it's nice to see that those conversations are happening at the state level. But again, it always comes down to where does that funding come from?
Right. Okay, so let's kind of change gears or get back onto the other tracks where we talk about pediatric care. For the clinicians out here that are listening, whether they work in the hospital setting or pre-hospital, and they are considering a career in flight, whether it's for general population or pediatric specific, what would be your advice to them in terms of like a skill set or knowledge area that they need to focus on to get into the pediatric realm?
So in pediatrics, I think it would be just getting that ICU level experience, the critical care piece of that. I CAMES is the accrediting body that oversees flight programs, and they require you to have a minimum of 3 years of critical care experience to be able to function in that role on a flight team, whether that's as a paramedic or as a nurse. So that means you have to have, as a paramedic, you have to have 3 years minimum in like a busy 911 system.
Hmm.
And then for nurses, it's ICU time. So I always encourage people to get a minimum of 1 year in the ER, just so that you, one, get to experience the chaos, but two, you develop those skills. Because sometimes in the ED, like you're jumping from task to task to task and doing skills, and you're repetitively doing them, and you're getting better at performing those skills and doing those in less than ideal situations, and then also under time constraints.
Hmm.
And then the rest of their time should be in the ICU, where you're looking at that bigger picture and the whole, the patient as a whole, and more of that mindset of, if I do this right now, what's going to happen in 7 days, right? Where in the ED and pre-hospital, it's almost always, what do I need to do right now to keep them from dying? And then up here, it's that in the ICU, it's more that critical care. You're monitoring. The running joke for me has always been trying to call report to the ICU, and they're like, "What's their urine output?" I, I have no idea. You know, they may have peed the bed. You can weigh the sheets when I get up there. But then when you're in the ICU and you're tipping the urine every hour and you're making
Mm,
all these changes and adjustments based off of what that urine output is, so you connect the dots
right.
between why they ask some of those what we feel like silly questions in the ED. But then when you're in the ICU, those are very pertinent questions and are driving the majority of the care up there. So you're getting that more critical care complexity. So I think if you're going the nursing route, I think 1 year in the ED and then get into an ICU and just be engaged and just be a sponge and soak up anything and everything that you can. Pay attention in rounds, listen to the docs when they're discussing the cases, and just pick up everything that you can.
Now, I have been through the Echo Heliops Future Flight Crew Academy, and most of my cohort that graduated in 2020 are flying. There's a handful that aren't for various reasons, not for lack of interest, but I still think about trying to get into that realm. I think one of the fears for me, and I'm sure this is a fear that is for all new flight clinicians, right? When you get hired on and you start doing your first flights, that feeling that you don't belong and you are not smart enough to do this. You're not sure how you pulled it over on them to get hired in the first place. Can you talk about that fear, that initial fear, imposter syndrome that new flight clinicians or those that are not applying because they don't feel smart enough or have I mean, if you have the 3 years, right, you've met that level of criteria, but how do you overcome that? How do you address that fear?
I don't know. I still feel it.
That's not helpful, Chris.
No, no. I think what happens though is you find yourself in rooms with people that are way smarter than you, and those are the rooms you want to be in. Like I've said this for a long time with the program that I work at. Oftentimes, feel like the dumbest guy in the room, and not because anyone else has made me feel that way, but myself. Like, I've not had one person that I work with be like, "You don't belong here. You're not smart enough for this." Or, they are very supportive, and they will teach you and coach you and talk with you and support you. And all of that stuff is just my own shortcomings and own thought processes, but it's because I'm surrounding myself with people that are stronger than me. And I'm constantly soaking up and I'm constantly learning from them and pulling from them. And I think that's the big thing is it's okay to not be the smartest person in a room. That's where you're going to learn, and that's where it's going to drive you. If you constantly find yourself as the most intelligent person in the room, you're in the wrong rooms, and you need to challenge yourself and get out there. So I think, and I think it's Sophie Fuller just did she did a whole lecture on uh imposter syndrome in the flight world. And I mean, it's real. It certainly happens, but I think it's, what do you want more? Do you want to overcome some of that awkwardness and uncomfortableness to live your dream, or do you want to kind of restrict yourself out of fear?
Right. And that's what the orientation process is for, is to help fill in those gaps and
Absolutely.
build that confidence.
Yep.
Now, we're going to kind of close out the clinical part of it with looking forward. So technology is always evolving. There's always new pieces of equipment, but what advances in medicine, portable monitoring, AI involvement, what do you see as the next big leap in pediatric emergency care?
Yeah, that's interesting. I think AI is going to play a huge role in the care that we provide. They've already started incorporating it somewhat into uh, the charting system as far as assessments and going into that, and then also Epic rolled out their big one that is going to create support in my chart where patients can actually log into my chart and see all their results and ask questions to the AI as to, well, what does this mean for me? And
Wow.
it'll be able to describe, like, collectively describe all that to the patient. And then what it also does then in the back end sends updates the physician, hey, this patient had these questions. This is what was addressed. This is what they were educated on. So then the physician gets that on their side of being like, okay, the family is aware of this, or this is where we need to lean into this a little bit more. That's going to be a huge part of it. But I think with any of the devices, as you mentioned with, like, I think 12 lead, I think that if they build it into it correctly, that the AI is going to be able to read the 12 lead way better than any of us can. Right now, we're still at that point where you don't even look at the description on the 12 lead because it's usually so far off,
Mm-hmm.
right? You're just looking at the 12 lead itself. I think there's components with ultrasound too, where they're building AI into ultrasound. So, like, as you're scanning, it's identifying the landmarks and the organs and the things that you're seeing,
Wow.
actually identifying it on the screen. So I think that's going to be everything is just going to continue to uh, grow. And I think the resources are there as well, like the references, being able to access those references and being able to dump in lab values into it and be like, what does this mean? What's my priority here? And
Mm-hmm.
having those. I'm one that I'm embracing it
Mm-hmm.
currently. I'm excited for it, and I think it brings a lot of potential.
Right.
I know there's some fear and uncomfortableness around it as well, and I think I have um appropriate amount of suspicion with it, but I think it will do a lot of big things.
And it's interesting because I am actually going to be interviewing for a future episode of the podcast a Yale prepared doctor of nursing practice who is working on AI integration in healthcare, is going to come on and talk about those very things, like where are we at now? What can we expect in the future? The pearls and pitfalls that come along with that. So that'll be a very interesting episode given the
Yeah.
current state of technology in the industry. Now, what is one thing you wish every healthcare provider, whether it's pre-hospital, in hospital, what do you wish that they would remember or take away with regards to treating a child in crisis?
So I think that we have to remember that just because it's a Tuesday to us doesn't mean it's not that family's worst moment ever. And I think we often get that tunnel vision of, this is what I do every day. I see the worst of it all the time. Some of these families have never experienced anything like this. They have no idea what it's like being in the emergency room and having a child that's sick. And I think we have to remember that. And again, it just comes back to that family centered care and including the family in all aspects and having those conversations with them and communicating with them and having a little bit of understanding of putting ourselves in someone else's shoes, I think.
So far, I've asked everybody this question. I'll ask you the same thing. Today's the last day that you can do what you do. Tomorrow, you have to start an entirely new career that cannot be in healthcare. What are you doing tomorrow?
Oh, not in healthcare.
Mm-mm.
I right away I was like, oh, palliative care.
Nope, that's
But no,
healthcare.
so not in healthcare. Oh, um, so I think I would be, I would probably be a helicopter pilot. So I look back and I think I would I'm jealous. Every time we go to a PR, I'm like, the cool guys sit up front, and I just sit in the back. So I think that would probably be it.
Well, Chris, thank you so much for coming on the podcast. This was something I was looking forward to. The insight that you provided was wonderful. Now, please tell people where they can find you across the social media platforms.
Okay. Yeah. Thanks for having me. This was a lot of fun. And like I said, I've been looking forward to it for quite a while. So, but the Blakery content pretty much on all of the socials, TikTok, YouTube, Instagram, Facebook, it's all under the Blakery content. And in the very near future, we'll be expanding out to reducing the pucker factor podcast as well. So we'll have some of that stuff, but it'll all fall under the umbrella of the Blakery content.
Now, where are you going to be speaking at? Tell us about some of the upcoming conferences that people can find you at.
Yeah, so November, I'll be in Charlotte, North Carolina at the International Trauma Life Support Conference. I'm very fortunate to sit on the editorial board for ITLS. So I'm pretty excited about that. And as soon as the new course is released, we're going to dive into the pediatric ITLS curriculum and rewrite that whole textbook and course from the ground up. So I'm super excited for that. Stay tuned for the updated PITLS course. But then I will also be in Tampa, Florida in January of 26 at the AMPA, so the Air Medical Physicians Association conference that's held within NAEMSP. And then in March of 2026, I'll be at Kalahari for the Critical Care Symposium there, and where I'll do the lecture and then also some breakout skills sessions. And then June, I will be in Austin, Texas at FAST 26. So the calendar is filling up pretty quickly.
All right, Christopher, thank you so much for coming on the podcast. And thank you all for listening. My name is Gary, the ER nurse, and you've been listening to Beyond the Call Light. We'll see you on the next episode.
Thanks for listening to Beyond the Call Light with Gary Cope. Don't forget to clock out.